All right, we're going to get started talking about diabetes today. Even though there's lots to cover in endocrine, I don't have anything in here specifically about other topics. Although make sure that I gave a really in-depth lecture about thyroid last semester, so please do look at that if you have questions. Let's see if I can move forward there. Okay, so this is about, I'm going to start talking a little bit about the diabetes self-management education support. This is from the CDC. And is really, oops, sorry, I don't know what that's about. And a great way is kind of what I was putting in the chat box earlier about really working on with patients on self-management of their in this case, diabetes, but I think that it applies to obesity and other issues as well, including depression and other things. So the first thing you want to really be doing is a health literacy screening and seeing where they are. How often do you need help from someone when you're reading pamphlets or other written materials? There are people who really, I mean, when they say you put your writing in an 8th grade level, it is very true to keep it at an 8th grade level. And I catch a lot of you also speaking at a higher than high school level. And so make sure when you're speaking to people also that you're keeping your terminology in a realm where they understand it, which can sometimes be hard. It means you have to kind of go define those words that you're using. And then how confident are patients filling out forms by themselves, just to kind of get an idea of where they are. And then you want to talk about them and kind of where they are. So assess their health. What is their style? How do they like to do things? We already talked a little bit about literacy, their history of diabetes, their history of being overweight, their history of depression. So although I'm specifically talking to diabetes at this time, please make sure that you know that you can apply this to a lot of different things. And I did take this, the way they wrote this, and I definitely took it out and am utilizing it in a slightly different way, just so you know. But what is their history of information about this, or the interest that they have? Did they want to learn about their diabetes? Did they want to learn about their depression and how to control it? When I think of specifically with the depression, like, did they want to learn, self-management techniques, like to control their anxiety and things like that? And I'm gonna repeat this over and over again. Every time I'm looking into the literature more and more, the literature is really saying that your relationship with someone is a partnership in the clinic, and that without the patient's effort, you will not be successful. All right, and then what interventions have they tried before? What can you get from that? What was based on clinical management, their educational needs? Do they need a full education program? In this case with diabetes, do they need to go to the diabetic educator and go to the full class? Or do they just need to focus on, one meal or something like that? That said, the diabetes educator, also remember that our folks who are on Medicaid and 18 or under can go to a nutritionist. After the age of 18, it gets really hard to go to a nutritionist. And so when you're finding young children who are, I will say children, period, 18 and under, who are overweight, please refer them so that they can get this counseling and this help before they turn 18, and it's no longer available frequently. All right, and then reassess the situation. So when they come back in a month, in 3 months, in whatever, how are they doing? So I like to, in my chart notes, I usually put SMG, self-management goal, and I write down what their goal was. So, the patient's goal was they're not good at taking their metformin. So their goal was to take that metformin consistently every night. And, and maybe they were going to walk 10 minutes twice a week, right? So I write that down in my note. And then the next time they come back to me, I say, okay, so how have things been going? I know you were having a hard time remembering your metformin. You made a goal to remember it. Have you been able to take it every day? Are you still forgetting some? You said last time I saw you, you were going to walk for 10 minutes twice a week. Have you been able to do that? If not, why? What's preventing you from doing that? And so you really want to work with the patient. So you don't want them to just make a goal. You want to follow up on the goal. It's part of being a provider and it being more individualistic with the care that you're providing, but it also makes them more accountable because they're going to come in, they're going to know you're going to ask that question. And when they know you're going to ask that question, they want to be able to give you that answer, right? We all know we're more accountable when someone else is paying attention. And then continue to support. Sometimes that means changing the goals. If my patient is now walking 10 minutes twice a week and taking their metformin every night, well, let's go from there. What else do we need to do? What's the next step? Do we want to increase the amount they're walking? Do we want to look at cutting out that, super latte every day, or continue with it. Don't stop at the minimum. Keep working towards something. And again, this can take many, many months. This isn't something that happens overnight typically. And just kind of again, to apply this to everything, when I'm doing this with patients, I often will have them come back in a month or two just to reset, refocus. I don't want them to forget about me. I don't want them to forget about the goal that they made. All right, so kind of moving back into our diabetes realm. Just a update, when you're doing your diabetes diagnosis, please remember that when you're doing a point of care A1C, it is no longer diagnostic. It is not diagnostic, excuse me. It is also not diagnostic without any symptoms of hyperglycemia. If you have, I apparently misspelled or had a typo. It requires, if you have an A1C of 6.5 or above, you need 2 tests to confirm that diagnosis. If you do not have, if you don't have any hyperglycemic symptoms, people will often say, every time I eat, I'm so sleepy. That is a symptom. Or they'll notice that they don't feel good after they have sweets or something like that. So those are symptoms of hyperglycemia. It doesn't have to be ginormous. It just has to be some kind of symptom that they're having. With older adults, it's really reasonable to have that A1C 7 to 7.5. So the reason we really want the A1C lower is the lower the A1C, the less complications, lifetime complications someone is going to have. So if someone comes in and gets diabetes at 40, we want pretty tight control with that patient, because the lower that A1C within reason, then the less likely they are to have the eye issues and the microvascular complications, the renal issues, the issues with neuropathy. So you really want to be thinking about that. However, when you have somebody who's 70 or they're 75 or 80, a 7 to 7.5 is fine, because you're not working to prevent renal issues as much, or eye issues as much, particularly when they get diagnosed with diabetes at that age. The other thing is that we need to be, our older adults are very sensitive. And so when their blood sugars are fluctuating, when they get low, they're much more at risk. If they have a hypoglycemic event, it is going to be much more significant overall than it would be if you have somebody who is who's younger. They won't bounce back the same, and it can actually lead to early morbidity. And then also patients with very complex health conditions or poor health rely more on how they're feeling rather than their A1C. You don't want them to be hypoglycemic. You don't want them to be hyperglycemic. And obviously with the majority of your patients, we're going for, between the 6 and the 7 is really the ideal target. All right, so this is the one I'm going to look at in depth here today. So this is this amazing flowchart. They did update it. The ADA has been great. If you go to their website, they have they've been pretty consistent about making updates. And so when you go in there, you can see just little changes that they have made over time. Like it used to be that you needed 2 fasting blood sugars over 126 to make a diagnosis. Now you need 1. And so things have changed. So your first line of therapy is metformin. So start the metformin, keep the metformin. Metformin with lifestyle. Okay. So when you have pre-diabetes, you really want to focus really on the lifestyle changes first. However, metformin is also actually indicated in prediabetes, and so it's something to be considering in your patients. It's a discussion to have. If they're really hardcore about, nope, I don't want to take medicine, I want to work on this on my own, then lifestyle is enough. But putting metformin and lifestyle together is really what you want to be doing when someone is first diagnosed with diabetes, if they're not already on the metformin. And then we're going down, and we can see here these indicators of high risk or established ASCVD or CKD or heart failure. Okay, so those are special cases. We're going to go back to that. You can base this ASCVD on, they have a history of MI, they have a history of stroke, they have an ASCVD score of 20 or even 10 or 15. CKD, obviously you're checking their renal function regularly, typically with a CMP. And so looking to see where that is. When I think of CKD as far as following this, I think of like a stage 3A or 3B CKD, not a stage 1 or 2. Although these medications, the reason for this differentiation is that the medications over in this section are actually protective to the heart and they are protective to the kidneys. And so just like we want to stick someone on lisinopril to protect their kidneys, we want to stick someone on these medications to help protect their kidneys. So even if they don't have significant CKD, you might still want to use, you might want to go down this this path rather than going over to the other side. All right, so so if the A1C above is individualized or individualized target, proceed as below. So above individualized target, excuse me. So if they're not where you want them to be, we want to go to our next step. Okay, so this is where I want you all to start, is on the left side. DPP4 inhibitor, GLP-1 inhibitor, SGLT2 inhibitor, and TZD is your first line. I have to say these three are where I would go next. Obviously, so if you use one of these guys, moving down, just so you know, with the GLP-1s, they now have an oral, so they're not all injectable. And then, I don't know, I'll get more into it in a bit. Okay, so after you have added one of these medications, you need to give them at least 3 months to continue to work on their lifestyle and take their medications consistently. When you recheck their A1C, then we decide whether or not we're going to make additional changes. You may have seen the A1C come down some, and you may not want to make a significant change. Or you may have seen it come down all the way and you're good. You don't need to add it anymore. And you can see that, like, if the A1C remains above target, this is when we're going to add another oral medication. And that was one of the, I believe, on one of your quiz questions, that if you follow this guideline, here's your metformin, that was the first med. Your second med is going to be one of these guys here. Your third med should be one of these guys here. And we don't hit insulin until later on. All right. So typically after you add a second, again, you want to give them 3 months, 6 months to see how this is working. When I say that, remember that, like, maybe you're giving a lower dose and you're going to increase to a higher dose. A number of these medications can cause stomach irritation. And so you want to gradually increase the dose rather than quickly increase the dose. This is dependent on the patient and how they're tolerating it, right? So maybe this process of starting on metformin, adding DPP4, GLP-1 or SGLT2 or TZD takes 6 months or a year. That's okay. We want to get things down as we can. Now, if you're talking about an A1C of 9 or even 8, you want to go a little faster than that, or above 9, I should say. But if someone's, hanging around that 8, 7 area, you don't have, it's not a race to get this down. We want to get it down gradually and in a way that's not going to impact the patient, make them feel uncomfortable. Okay, so if your A1C continues to be above the target, you want to continue with the addition of other agents. It says outlined as above. So you can add additional agents. These guys typically don't have interactions with each other, and so you could be on more than 2 of them, more than 3 of them. That's okay. However, somewhere if you've kind of maxed that out, their insurance isn't covering anything else, this is when you move to insulin. So you want at least 3 of those alternatives to insulin on board before you add the insulin. Part of the reason why is because insulin's a high-risk medication, is one of the reasons. The second reason is because insulin causes weight gain, and with weight gain, obviously diabetes tends to get worse. And so the insulin in the body increases the appetite. So when the appetite is increased, patients eat more and therefore gain their weight. So we want to avoid the insulin, and we want to avoid larger quantities of insulin when possible. All right, so, and this is actually says, consider a sulfonylurea or basal insulin. Okay, so this is 4th line. If you want to add that sulfonylurea because the patient is against insulin, I guess that's okay. I really, and actually data says, the ADA says, don't threaten your patients with insulin, but they do need to know that, the next step will be insulin. Nowadays, insulin pens are widely used. And so I worry less about patients with trying to figure out the needle and getting the right dose. It's a little bit safer when they're using the pen. Also the needles with the pens are quite small, and so the discomfort with it is pretty minimal. I am not a fan of sulfonylureas. There's pretty good data out there that says that sulfonylureas, while they help the pancreas create more insulin, it also will burn the pancreas out. So if you have a patient who's been on the sulfonylurea for 5 years or so, and you take them off of it, sometimes you'll find their A1C doesn't change. That's because the sulfonylurea burned the diabetes, in addition to the sulfonylurea, burned the pancreas out, and it had no more insulin to produce. And so that sulfonylurea wasn't really doing any good. And that's another reason to potentially go to insulin rather than sticking with a sulfonylurea. And then you with type 2, and this is all type 2 patients. This is not type 1. Type 1 only gets insulin. With these type 2 patients, you want to then stick with a basal insulin. So one of the things you want to do is with a basal insulin, you're looking at their morning fasting sugar is really indicative of the basal insulin being at a good dose. You do want to monitor throughout the day, especially as you're changing doses. My personal method is different than others, but I like people to keep a log and check. If they can check 3 times a day, that's wonderful. But sometimes I want them to check before a meal. Sometimes I want to check after a meal, or specifically after a larger meal or a normal size meal. So I'm having an idea of 2 hours postprandial, what their sugars are and where they're going, to try to avoid getting them too low, right? I don't want them to be hypoglycemic. The other thing is I don't want to miss those mealtime spikes if those mealtime spikes are occurring. All right. And then basal insulin does have a lower risk of hypoglycemia than the immediate release insulin. When you continue, somebody's on these medications, you've kind of maxed them out on everything, they're on their basal insulin, that is when you need to start mealtime insulin with your diabetics. And that is something that you want an immediate release, and take it with each meal. I don't say take it 3 times a day because it'll make somebody crash. You only want to take it with meals. All right, so now I'm going to go down my second line here. The first one was a compelling need to minimize hypoglycemia. This is a compelling need to minimize weight gain or promote weight loss. So our number of our patients fall into this category, right? While we're going from left to right, a lot of our patients are going to fall into this category. And so we're going to keep them on the metformin. And just kind of a note, metformin, I sometimes will tell patients that it does cause some weight loss, but the weight loss that it causes is about 2 to 2.5 pounds. It's not very significant. And and probably likely to the stomach upset, although that's probably true as well with the GLP-1 inhibitors. All right, so with this, you want to think about either an SGLT2 inhibitor or a GLP-1 a receptor agonist. Excuse me, I've been saying that wrong. Both of the GLP-1 receptor agonist in particular has some good efficacy with weight loss. Let me see if this, okay, so I'll go back to that slide in a moment, but I want you to look a little bit about, here's your incretins. Your GLP-1 is, that helps you feel satiated. However, the problem with it, it's quick, right? It's like it's a minute or two. So when you have a GLP-1 receptor agonist, you're preventing the GLP-1 from going away. You're keeping the GLP-1 there. So that sensation of feeling full lasts longer. The purpose of, and I know that this doesn't have the SGLT2s in here, but the DPP4s, the purpose of the DPP4s is the DPP4 is the enzyme that breaks down the GLP-1. So the reason it only lasts for a short period of time is because it's being broken down by the DPP4. So that is the purpose of this. When we give a DPP4 inhibitor, you block the DPP4s so they can't activate or inactivate the GLP-1. A little confusing, but I hope that that's helpful. And then your GLP-1s also help stimulate your insulin release. So if you have increased GLP-1, you have increased release of insulin, also inhibits the glucagon release. So this is in your liver when the body's making glucagon in the liver, it's going to inhibit that glucagon release. So not only does it make you feel satiated, it increases your insulin release and it decreases the amount of sugar being released in your blood, and as a final result of lowering your blood glucose. All right, let me go to the prior side. The SGLT2s work significantly different than that, but we'll get to that a little later. I just wanted to make you understand why, or help you understand why those are specifically good for weight loss. After adding either a GLP-1 or an SGLT2 with patients who need to lose weight with their diabetes, then you want to move forward and you want to add the other one, right? So if you added one, you want to add the other one. If it remains above target, so this is quadruple therapy, similar to where we were with quadruple therapy over here. You want to stay on those medications. And then you want to add, ideally, a DPP4 inhibitor onto that. And as you saw, the purpose of that DPP4 inhibitor, you can see it over here, but it doesn't seem to have the same impact on weight as the GLP-1 inhibitor. However, if the patients aren't tolerating the GLP-1 or the SGLT2, if there's something going on, then you might need to stop these. And that is true, of course, about any of these medications. All right, and then if you're still not getting the A1C that you want, if a DPP4 is not tolerated, or it's contraindicated from some reason, like a allergic response or something like that, or a patient is already on a GLP-1 receptor agonist, then you need to be very careful about the addition of a TZD or sulfonylurea. Take care of that and just be aware of it, because the sulfonylurea has more insulin secretion, and that you can cause more hypoglycemia. Similarly, that basal insulin, also you need to take care that you're not causing hypoglycemia. Metformin does not tend to cause hypoglycemia. So it is considered a medication that does not cause hypoglycemia. I won't say that's ever 100% true. There's always differences. All right, so you mostly at this point, their insurance companies are covering these medications. They may not cover all of them. I know that sometimes GLP-1s can be used for weight loss outside of diabetes. And so I've tried to use GLP-1 as like a first line or in pre-diabetes. In some insurances, no problem, they cover it. Other insurances, no way. That is off-label use, by the way. Well, I don't know, I guess it is used for weight loss. It has an indication for weight loss. but in conjunction with another medication. But when someone has prediabetes or diabetes, sometimes that's the medication I go to for that reason. If their A1C is in 6.5 or above, I'm going to metformin first. And so that therein is my off-label use. All right, so if cost is a major issue, which is certainly with some people. So the people that I see cost an issue with is those folks who have Medicare in particular. And these are expensive medications. And although Medicare Part D is covering them, they hit that donut hole. It often occurs around August, September, October that they've been paying all year, these kind of relatively reasonable rates, and all of a sudden they've hit their donut hole and their insurance isn't covering anymore. Hopefully someday this will be fixed. Write your legislators. That's my opinion on that one. However, while they're in that donut hole, some of my patients will change from their SGLT2 or GLP-1 or DPP-4, and they will actually change to a sulfonylurea or a TZD at that time. You will note over here that there will not be any TZDs. That is because TZDs can cause heart issues potentially, and they have been associated with rare occurrences of heart failure, but also can be definitely associated with like lower extremity edema and weight gain, but I believe the weight gain is secondary to the edema. And then with costs being an issue, if one isn't enough, then you add the second one. If they're still above target, then this is, again, it's your fourth line treatment to start with insulin. Okay. All right. And then again, we already discussed that we're reviewing treatment and looking at this every 3 to 6 months. And again, you may not start on the highest dose of sulfonylurea. You may not start on the highest dose of any of these medications. You want to gradually increase. And I think I have a note about metformin, but not sulfonylureas. You need to watch your CMP to watch the renal function with sulfonylureas. Okay, so here we go. We have somebody who has established ASCVD, they have kidney disease or heart failure, then we're going to continue on that metformin. Metformin has amazing data behind it. I know some people really hate the fact that it can cause diarrhea or stomach cramping or whatever, but the deal is it has wonderful data behind it about what it does for morbidity and mortality within diabetes. All right, so I'm going to start over here. If someone has ASCVD or indicators of high risk, so established ASCVD or indicators of high risk such as age over 55, my apologies, my slide is small. They have a history of over 55 with some kind of MI or coronary issues, carotid issues, carotid plaque in excess, or low extremity artery stenosis greater than 50%, or left ventricular, I believe that's left ventricular LVH hypertrophy. Thank you. Sorry, I'm
sorry. Where are you? Oh, now I see.
I'm over here.
Yep.
Sorry, I did the no risk factors first. So for your average folks. So we're over in this first column now.
Okay.
And my apologies, I cannot read that teeny tiny print. And then we want to move to, if their metformin isn't cutting it, you want to go to your GLP-1 receptor agonist. Because that has proven cardiovascular benefit, right? Similarly, your SGLT2 inhibitors also have cardiovascular benefit. So with the SGLT2 inhibitors, you guys can tell me if I'm wrong on this, but I believe my SGLT2 inhibitor is my, I always get them confused in my head, I'm sorry. What's that?
Glyphosins.
What is it? Like
Nuvia?
Jardians.
Nuvia. Ooh, okay.
Invokana.
I think I remember the last four names. Glogene. I think they.
What's the one? What's the Flozins? What class are the
Those
flows?
are SGLT2s.
Those are the SGLT.
Those are the SGLT2s.
Yes.
Yeah.
Okay, that's what I thought. I'm sorry. I thought that's what you were telling me that Januvia was. Okay, so the SGLT2s, if you remember last week, we were talking about heart failure. The SGLT2s make the glucose come out in the urine. It is a higher risk of having a yeast infection. It can cause some other complications as well. However, my point of this is when you're using it in heart failure, it actually is like a glucodiuretic, I think is what they call it. I don't know if that's a real word or if just a term people use, but so it does have some diuretic effect, and so using it in heart failure is particularly good. If with that they're still above their A1C targets, so we have 2 meds on now, and then if your patient's unable to tolerate those, you want ideally something that's going to have this cardiovascular benefit is where I am. Where'd my mouse go? There we go. So for patients on a GLP-1 receptor agonist, consider adding an SGLT2. So that would be your metformin is your first line. Then you have your second and third line, right? Up here. And then if put them on the other, if they're on one and put them on the other. All right. And then after that, then you're going to go to your TZD, your DPP4, but only if they're not on the GLP-1 receptor agonist. And then after that, you go to your basal insulin and finally to your sulfonylurea. So your sulfonylurea generally is your last choice. We just talked about the heart failure. The definition of that based on this flow sheet is under 45%. We talked about last week how that is when we really are starting to treat people consistently for heart failure, and following all those guidelines of making sure they're on their ACE and their beta blocker, et cetera. All right, and then we already talked about, so the SGLT2 is beneficial potentially in that population, and ideally that's enough to help control their diabetes. If it's not, then I believe that you can follow kind of the other lines. I don't think that there's any contraindication for that with heart failure. It's just that the SGLT2 is so good that we want to be using that first. All right, and so in kidney disease, we have to be careful. I have a slide a little bit later on that talks about metformin and kidney disease. I believe that you all know also when somebody's getting some kind of diagnostics with contrast, they need to stop their metformin beforehand and until their kidney function normalizes afterwards, because it is filtered through the kidneys. All right, and so after that with kidney disease, preferably we're going to the SGLT2 because there is evidence of kidney protection with that. Alternatively, or the GLP-1, which also has some benefit. And again, these can be used in combination and then if they can't afford these or there's some reason they can't have them, for type 2 diabetics with chronic kidney disease with a GFR under 60, and increased risk of cardiovascular events, we have fewer choices. We want to stick with the GLP-1 receptor agonist or the SGLT2 inhibitor. Okay, so that was a long time to spend on that slide. So hopefully that was helpful. I do think that getting familiar with this and knowing your meds is helpful. So I already used that one.
Dr. Matyac.
Yes, sir.
If someone's on like 3 different oral anti-hyperglycemics, and if you want to start basal insulin, do you take off some of the oral anti-diabetics or just continue? Okay.
No, you don't take them off. You keep them on.
Unless it's sulfonylurea.
Unless it's a sulfonylurea. Well, you can't.
Right.
You can use. So there's not amazing data, right? So if you're using a sulfonylurea or GLP-1, your risk of hypoglycemia is higher, and so you want to adjust slower. Patients will say, "Oh, but I don't want to stop that one." Well, that's okay. Sulfonylureas in particular, I like to take off because they scare me, and I don't think they do very much. And so I don't like to use those in combination with insulin. But if your patient wants to be on it, then you can, just work with them and have them monitor and make sure they're not having issues. And I apologize, I have some typos here. For the GLP-1 agonists, per the guidelines, decrease other therapies if their diabetes is well controlled. You want to continue you want to discontinue DPP-4 inhibitors in the setting of GLP-1 agonists, and educate on the mitigation of side effects. So, for example, it can cause nausea. So they don't want to have, we were just discussing about the like people who have kind of gorge on their big meals. If they don't do that and they have smaller meals, they are less likely to have nausea, but they don't know that. So you need to tell them that, have smaller meals that will help prevent nausea. It's not just you, it's the medication that's causing that, right? It's not just you telling them to have a smaller meal. It's when you have a bigger meal, the medication, the way it works is going to cause nausea. Of course, we talked about education of diabetic retinopathy complications. We do want to avoid GLP-1 agonists in patients who have a history with gastroparesis or active gallbladder disease. Active gallbladder disease means that they have symptoms. If they have a history of gallstones or they have a history of issues with their gallbladder, unless they're having problems, don't consider it active. We have our contraindications here. History of medullary thyroid cancer is a little unusual, so I just wanted to point that out. Here's our SGLT2 inhibitors. These are ones, okay, this is why I have this up at the top, so I can remember. All right, so for our guidelines, decrease other therapies if well controlled on their diabetes. So kind of some similar stuff. We talked about the mycotic infections, yeast infections. Usually because it's the glucose in the urine, then you're having issues around the genitalia. Avoid hypovolemia. Make sure they're well hydrated. Obviously, it's a diuretic. We don't want that to happen, and it can cause orthostasis because when someone has when they're a little dehydrated. And educate on proper foot care. We already talked about recurrent UTIs or yeast infections. So I was looking at the data again about UTIs and SGLT2 inhibitors, and the data indicates that it doesn't really talk too much about recurrent UTIs or having UTIs. It talks about severe UTIs. And so the SGLT2 inhibitors are not likely to cause severe UTIs, but may cause UTIs. And so if that's happening to someone frequently, then we want to figure out what the best way is to handle that. Weigh your risks and benefits and make the decision with the patient. They're also at risk for hypotension, as we discussed above. And then here's your kind of, sometimes that this is SGLT2 inhibitors are what you want to be using. They're good options. Okay, so diabetes management and chronic kidney disease. I love this picture. It made me think of the food pyramid, but really these are your main things for all patients. Do you want smoking cessation, good nutrition, exercise, glycemic control, blood pressure control, lipid management? So my dad actually told me the other day that he was given a diagnosis of CKD, and he's like, and I said to him, he's just like every other patient. Who knows what they really told him? I'm just repeating what he said to me. He's like, well, what can I do for it? And his blood pressure is controlled. He's on cholesterol medication now. So, but he smokes. Well, he said, well, nobody talked to me about my smoking. And I want to just shake him, right? Like, this is not okay. You need to stop smoking. That has a huge impact on your kidneys. Having being normal weight and not being overweight has a big impact on your kidneys. Exercising, that has an impact on your kidneys. So I think that people forget these things, but think about your kidneys as any other part of your body, that your body is going to function better and be healthier if you're of normal weight than if you're not. So taking these things into consideration, I think, is really important. And then when you have renal failure and diabetes, you want to get that SGLT2 inhibitor because it helps protect the kidneys. And obviously work with the RAS, the RAS system, to make sure that you're using a medication in there for that as a blockade, like your ACE or your ARB, ideally. And then if needed, antiplatelet therapies, and that's not a topic for today. And then this just kind of has the recommendations. I'm not going to read that out for you. It talks a little bit about the, GFR. Similarly, this is for your reference. It's not really something that I'm going to go through in detail. I put it in here because I wanted you to recognize that if a GFR is less than 30, you need to stop the metformin. That's a big, big thing. And it's not something that I feel like we hammered home in pharmacology. So I wanted to make sure that you had that. You may need to adjust the dose at some point. You can see if your GFR are below 60, you probably want to adjust your dose of metformin. It just means you're not clearing it, right? So the patient should get the same effect because they're not clearing all of the medication, so it's still in their system. So I feel like we talk about the Samoji effect and we talk about all these things, but one of the things that I guess I have a hard time envisioning things, which is one of the reasons I like this slide. We want to think about what's going on with the patient. We can't necessarily see it. I have a slide in here a little bit later about continuous blood glucose monitoring. Excuse me. Which can help identify these issues. So sometimes you can get them like that, you can get a sample for a short period of time to give an idea. Even if somebody uses it for like 3 days, you will get an idea of what's happening. However, with our folks who are sticking themselves longer, we want to use it. It has a good indication and should be covered by insurance. However, this slide, sorry, I'm getting ahead of myself. This slide is really about looking, where's your fasting blood glucose, right? So here you are at 6, 7 in the morning, where we want to be looking at what your fasting glucose is. That's giving you an idea of what your basal level of insulin is in your body, and if it's sufficient, your basal level of insulin is sufficient to be able to cover your elevated sugars with diabetes. And then we typically go up with meals. So this is like this is an example of someone in particular who, their noontime meal must have been larger or carb heavy. And so they went higher. So if you had an A1C of, let's say you have an A1C of 9, their sugars in the morning are consistently at this beautiful, like 120 level. And their before lunch look good and their before dinner look good. Why is somebody having, why is their A1C 9? So something like this with continuous blood glucose monitoring can be helpful. This is also postprandial, right? So if you're trying to figure this out, then instead of having them check their sugars before a meal, have them check their sugar after a meal. Can anybody just tell me what medication would you give to address this? Anybody know?
Which insulin or like?
Yep, insulin.
Aspart or?
Yeah, your immediate release insulin is going to help with that. All right, so then you have this person here, at bedtime, maybe they're a little on the high side, but all night long, they're really up. And so trying to figure out, it's hard to figure this out. People aren't, you don't want to wake them up in the middle of the night typically and have them check their blood glucose. However, if they were on insulin, giving them an insulin in the evening may help address that. Even though our long-acting insulins are really amazing, when people are on high doses of the basal insulin, or if it just doesn't seem to be working, I will separate the dose out and give them a morning dose and an evening dose. And that often will hit something like this. That's just not getting covered by the insulin, even though in theory it should be covered. And again, this is somebody who, I don't know what meds they're on, I would want to increase their other medications before adding on an insulin, certainly, but I want to be monitoring that. So we want to be talking to patients every visit they come in. Are you having hypoglycemia? When is it happening? What could be contributing to that? I took my insulin in the morning and then I forgot, I skip breakfast typically. So I don't, that can be an issue. All right. Just a note, because I was talking to somebody about a patient that was, having a really, really hard time. But they were on a low carb diet and they're diabetic. And so it was really harsh on their body. And they were not getting good control of their diabetes with a low, like a, I don't mean like, I mean a low carb diet, like a ketotic diet, because it puts them at risk for going into ketoacidosis rapidly. All right.
I have a question really quick on treating for like your long acting. Like, let's say your patient's having like the Shimoji effect quite a bit in the morning. How do you, like, what best numbers are you looking at to dose their basal when they're spiking in the morning regularly?
So, okay, thanks. I must not have said it clear out. So you typically, to look at the basal insulin, you're looking at their morning fasting. And that's usually a good indicator of what's normal. That last slide, which I'm going to go back to, if this patient had an A1C of 9, but you're getting a morning fasting of 100, you're getting an evening of like, 130, 150, something like that. Not horrible. Why do they have an A1C of 9? Like, that doesn't make sense, right? So that's when you're worried about the Shimoji effect. And that's when you would dose an insulin in the evening time, maybe with dinner or maybe at bedtime, so that it does take effect at night. Those long-term insulins, they often will last like 16 or 20 hours, but they're not enough to quite get it through. And think about, even though they're supposed to be flat, they have a bit of an arch to them, right? Everything does. You take it, it kind of goes up and then it kind of goes down. And so if it's going down around here where the sugar is going up, giving a second dose of basal insulin in the evening might be enough to get it to go up and catch them
in the morning. Okay.
Yes. However, like if they were taking, let's say they were taking 20 units of insulin every morning, I don't want to give them 20 units of insulin in the morning and then I add another 5 units at night. I want to give them 20 in the morning and then, or I'm sorry, I want to give them maybe 15 in the morning and 5 at night, or 10 in the morning and 10 at night. You may, after 3 months, you may want to increase that, but you don't want your patient getting hypoglycemic on you. So better to go slow. And typically, and I don't remember if we've talked about this previously, but typically when you're adjusting insulin, you can start increasing by like about 2 units of insulin at any, like 2 units of insulin every 2 days is the frequently used algorithm for adjusting insulin. More than that can cause too drastic of an increase. You also have to assess your patient. Who is your patient? Do they understand what you're saying? Because I feel like sometimes I'm talking to these little old people and they're just not getting it. Like, so when do I do it? What do I do? How do, like, and I don't feel safe with them. And I'd rather adjust them infrequently, or, follow up with a phone call or something like that. Or what I will do is, sorry, my internet is not awesome. Frequently what I will do is have them, I will write it out for them, an entire log of today, this is tomorrow's date. You're going to increase 2 units and you're going to stay on this quantity on this day. And then the next day I'll put the date for the next day and have the units that they will take the next day, and have them I go in, and then I will actually have them write down their sugars next to it. So when they come back in and bring me their log, I can see how much insulin they were taking on what their sugars were on those days. But people who are not quite getting it, giving them step-by-step instructions is really helpful. And again, as much as we use insulin all the time, it is a risky medication for sure. All right, things that we need to be considering in management. When was the A1C checked? I think this is something that I got my slides out of order. So it was, and what have we done since it was checked? What insulin is someone taking? Whether the blood glucose readings, when are they checking their blood glucose readings? What time of day is it? How often are they taking them? Do they have some symptoms of hyper or hypoglycemia? Are they adherent with their meds? What about their diet? All right. And then just kind of a reminder, and I'm sorry, like I said, that slide was a little out of order. With your type 1 diabetics, they're going to need a basal insulin, but they're also going to need insulin with meals. Type 2 diabetics, you want to use your alternatives to insulin first. And so insulin's going to be fourth line unless they could not tolerate one of the medications or some of the medications. When adding insulin, use with this was new information, and actually when I was looking at this, I read two different things. I read one with your type 2 diabetics to start basal first, and then I read this one. I didn't put a citation on this. The ADA says add basal first with your type 2 diabetics, and then the other article I was reading said to add with meals first, which was contrary to what I was anticipating. And so I guess my thought about this is I would use basal for now, but keep your mind open and keep your ears open for updates. All right, ensure the insulin and the type of dose is aligned with the meals. So typically with most insurances, we can use the basal and use immediate release with meals, so it's pretty straightforward. If you're using a 70-30, if you're using an NPH, you want to really pay attention to what is going on. So if you have an NPH, for example, it's going to peak in 4 to 6 hours. So if they take it in the morning, it's going to peak maybe at lunchtime. So you want to make sure that that's when they're eating their lunch and they're taking it accordingly. Last I checked, Kaiser still didn't use the basal insulin. They used NPH. So if anyone's in Kaiser, that's an interesting little thing, I guess, to look at those, because otherwise you don't see a whole lot of NPH these days. And an AM hypoglycemia suggests that your basal insulin is low. This is for your information. Dr. Martin is going to give you a separate PowerPoint on, and not a PowerPoint, well, probably a voiceover PowerPoint. That's what she usually does on insulin. So I'm going to leave this for your reference. But similar to the one that I just read through, when you really take the time to stop and read every line, they're pretty good. It just is really arduous to look at that much stuff. I already talked about the continuous glucose monitoring. Mostly it's needed for someone who's got like 3 injections of insulin daily and 4 glucose checks. That's who it's covered by for your insurance. Sometimes you can get that sample. This is again just straight from the ADA for your blood pressure control. And of note, when you have the choice of getting someone, I mean, you take it with a grain of salt when I say this, but if you have hypertension and you have diabetes, and let's say they're just both moderately elevated, right? Or moderately an issue, you want to treat the blood pressure before you treat the sugar. Now, if you have someone who has a blood pressure of 150/88 and an A1C of 10, please disregard. Take that into consideration. Did you have a question? Okay. So I want to go through this case with you really quick. Oh, we are over time. I might have you guys go through this case on your own. And I also gave you some cases in the on Sakai today as well. But essentially this is a guy, like if you were thinking about changing his dose based on what he said, you need to look at it more closely. It's not just straightforward. So that initial case didn't have all the details you need to determine whether or not you need to make a change. So you really need to be asking all of these questions if you're going to be making a change specifically in insulin. All right, now I have gone over my time. My apologies. But does anybody have any questions?
I have a random question, not about this.
Do you want me to stop recording?
Huh?
Can I stop recording?
Yes, go ahead.